Hi everybody, it's Tinashe here. I'm just going to share with everybody some of the stuff that we learned at Glenfield. This presentation is called TEGs in ICU, and basically just going to start off with what does TEG mean? Well, TEG stands for Thromboelastography. And as you can see on the machine, on the picture I've got over here, that's the machine over there, and it's called a thromboelastography. And some of the underlying principles behind the use of this piece of technology, which is a piece of technology that is primarily used in theaters and in sort of theater environments, places where patients are likely to be bleeding quite a lot, where we find like clotting disorders and bleeding and stuff like that. But the principles obviously are the formation of clots, the intrinsic and extrinsic pathway. I'm sure you know everything, you know all about that stuff. What the gentleman at Glenfield was telling us is that, although this is like an established sort of principle, intrinsic and extrinsic pathways, etc., they're quite difficult to measure. At the end of the day, it's a very complicated process. It's not as simple as people would have us to think. It's quite difficult to measure, and it's a dynamic process. Clot formation isn't just something that just happens. Because what normally happens is we take a sample of blood, we send it to the laboratory, they put it into a machine that spins it around in a centrifuge, separating all the blood components, and then they do some kind of test in a static environment, and then we get the results from the lab. But this is not a real indication of the patient's coagulopathy, because it's been happening ever since the sample was withdrawn from the patient, that the blood started clotting, and ever since that point things have been changing in that sample, especially if you during the time it's in transit from the lab, from the ITU to the lab, and then all the spinning and everything. It's a dynamic process, and it needs to be treated as such to get accurate results. See, lab tests such as APTTs, which we use, and INRs, these are quite static, as I was saying before, whereas the process of coagulation is actually quite a dynamic one. In addition to that, they only sort of give us an indicator of how quickly, at the speed, at the rate at which the clots are forming, or the coagulation of the blood. But there's no data at all in regards to the quality of the clot, and how long and no indication of how well the blood is clotting. It just tells us the rate, but not the quality. It doesn't tell us anything about the dynamics of the formation. It's just a number telling us, it's taken this much time for the blood to clot, but we don't really have an indication of how are the platelets functioning, how is the fibrin interacting, at what rate are they interacting, is the bleeding, if someone's bleeding, are the clots likely to be strong enough to stop the bleeding on a long-term basis? We have no idea of this. Sometimes you can have a patient with like a few platelets, a low platelet count, but they're clotting fine, sometimes you can have someone with a normal platelet count and they're still bleeding excessively, and it leads to like people trying to guess what's going on because you've got absolutely no data on the dynamics of the formation of the clot. It's just some figures. Well, this technique was developed in 1948, and it was used primarily for liver transplant management. So why should we use it? Why should we use TEGs at all? What's the point of having them in our unit? Well, the difference between TEGs and traditional methods of measurement is that TEGs measure the whole process. They don't just measure the speed at which the blood is clotting, but they measure the whole process. They measure the process of clot formation and clot dissolution. That means that they not only give a graphical representation of how the clot is forming, but they also give an indication of how long that clot is likely to hold, and the sort of quality of that clot, and when that clot actually dissolves. So you get an idea of your patient's actual coagulation status, not just the rate at which the blood is clotting, which is an inaccurate rate because the blood has been tampered with anyway. Like I said, this is comparing to conventional point tests, which just like platelet counts and APTTs and fibrinogen counts. Like I said before, it was like just trying to highlight the difference there. So what's so beneficial? What are the benefits of using TEGs in ICU? Well, these allow for global is spelled wrong there. Global assessment of hemostatic function. It's a overall picture, a much wider picture. You can even liken it to using triangulation, in research, because you're not just using one method of trying to assess data, but you come in at it from different angles, so you get a multi-dimensional sort of view of the coagulation status of the patient. Well, it starts off with the interaction. This process gives you the whole sort of clotting cascade, starting with the interaction of platelets with protein coagulation cascade, moving on from the time the initial platelets and fibrin start interacting to platelet aggregation, all the way to how the clot is strengthening. This system gives you a graphical representation of all this, to the fibrin cross linkage of the sample to the eventual clot sort of destruction. So it gives you a whole sort of the whole picture. It gives you, like I said before, the time, the rate at which the clot is forming, the stability of the clot. This gives you an indication of how well the clot will perform its function. That means that you'll know whether or not, if your patient is bleeding, first of all, you can distinguish whether the bleeding is being accurately distinguished, whether the bleeding is a result of a nicked artery. In that case, the patient will need to go back to theater, or whether or not that's because of a clotting problem. And if it's a clotting problem, it'll give you an exact sort of picture of what exactly is wrong with the blood, with the clotting. If it's what this machine can do is it can actually, if someone is on heparin, you can take a sample and